everyone, and we really appreciate you being here tonight. We heard that the weather isn't the greatest and that, but yet you still, committed to attending our session. So we appreciate you. We're grateful for that. So tonight we really just want to talk about palliative care, good practice for people living with intellectual and developmental disabilities. So just quick little introductions. My name is Janet Elder. I'm a palliative pain and symptom management consultant, as well as the co-chair of the IDD Provincial Palliative Care Committee. We also have Tracy Human with us, who is our chair of our committee, as well as a PPSMC as well, and she's out of the Toronto area. And newer to the committee, as well as to her role as a PPSMC, is Disa Clifford, who's been kind of in the background and helping us to make the presentation as pretty as what we can make it. So kudos to her for that. We appreciate it. All right. So our objectives for tonight. I'm just gonna wait for that next slide. Oh no, I jumped ahead. We gotta take care of that business stuff. So we gotta do our disclosure slide. So if you want to just go ahead, Tracy, next slide. So with regards to presenter disclosure, we've got no relationships with financial interest, the grant, research, or support, nothing to declare. Speakers Bureau honorarium, nothing to declare. Consulting fees, nothing to declare. No potential for conflict of interest, and no financial support. This is clear. Hopefully tonight will help you to understand that the early identification when it comes to people living with IDD, and really being able to understand those IDD specific tools to help us with that early identification. We're also recognizing that people with IDD have distinct considerations when it comes to pain and symptom management. Once we put that all together, really helping you to look forward with regards to that advocacy piece. And it's such an important part of what we do. Looking at palliative care with health service providers, of that developmental service professionals coming together to really make that good practice and make it the model of care, not just something that we hope as an afterthought, but just making it the standard. All right. Next slide. So let's talk about palliative care for people living with IDD. We know when it comes to people with living with IDD that they really lack that equitable access when it comes to palliative care. And that really includes providers with, when they have that confidence and that competency to really provide that IDD specific palliative care. We also know that the tools that we have, those existing frameworks and tools, they don't necessarily transfer well to people living with IDD. Here in Windsor, we have some really good physicians who do really good, they're palliative physicians, and they provide great care. And prior to them becoming aware of the work that we do, they were struggling. They knew that the tools that they were using weren't the right tools, but they didn't know anything else. So thankfully, through the work that we're doing, that'll change things and people will start using the appropriate tools. So how did we get here? So our founders came together in 2020 and really recognized again that lack of equitable access when it came to palliative care. So in 2021, there was a call out for membership, and which resulted in about 40 people coming together from across 22 organizations across Ontario to kind of begin working on this IDD palliative care resource guide and toolkit, which was really meant to act as a supplement to the existing OPCN framework toolkit. So why do we call it good practice, not rather than evidence practice? It's always about evidence practice, best practice, but that's not the language that we use when it comes to the IDD sector. So why not? Why do we only say good practice? Well, the bottom line is when it comes to that evidence-based practice, it hasn't been really well established in the IDD world. There's been challenges when it comes to the research part of it. There's those barriers. People don't even appreciate the number of people living with IDD. On a system level, there isn't that awareness of the need for doing research for IDD. So regardless, our aim is always to provide good practice. And that's how we live. We also know that the developmental sector, that's the term that they prefer. And since they're the experts when it comes to IDD care, out of respect and appreciation for the work that they do, we call it good practice. All right, so this is when we now we're going to go and have our audience, do a little bit of work for us. So we just want to kind of invite you to answer the following question. So how comfortable are you in delivering palliative care for people living with intellectual and developmental disabilities? So your choices are not comfortable at all, some comfort, comfortable, or very comfortable. So we'll just kind of give a seeing quite a range. Really kind of a couple of not comfortable, but some comfortable, but kind of mostly not comfortable to very comfortable, which is pretty impressive. But what we do know when it comes to healthcare providers, they really lack that confidence when it comes to IDD care. And that's evidenced by the research and just the different outcomes. We know that people with IDD have their own specific culture. So those of us who are not very comfortable, we don't have that appreciation of that cultural sensitivity or even the humility that goes around with it. Why are we not kind of developing that comfort? We have our two ministries. We have the Ministry of Health, we have the Ministry of Children and Community and Social Service, and they're not even communicating. So there's really not that awareness when it comes to being able to highlight the importance of providing good palliative care when it comes to people living with IDD. Most of us generally can say initially that we're not very comfortable with it. We're kind of ignorant when it comes to the needs of this particular population. We know just even when it comes to care for people with IDD, we don't even do the basic stuff. Often we don't do any of that screening. We don't do any of that, things like mammogram or ruling out colon cancers, things like that. So they really kind of fall under our radar. So hopefully after tonight, we'll kind of bring a better awareness of the importance of the work that we do for this population. So we just want to spend now a little bit of time talking about what IDD is. And we'll go to the next slide, please. All right, so under the, as defined under the Ontario Service and Supports to Promote the Social Inclusion of Persons with Developmental Disabilities Act 2008, and I can never just get that off the top of the tongue. I always have to read it, so my apologies for that. But when they talk about IDD, they really define it as an umbrella term for disabilities involving significant limitations in cognitive and adaptive functioning. And these limitations present themselves before the age of 18, are likely to be lifelong in nature and affect major areas of life activities. We also know that under the DSO, or the Developmental Service, Ontario is where that's our central point access as being able to access services for somebody with IDD. So it's similar to what we know as home and community care services, but this is specific to IDD. And there's some criteria to be able to access those services. So again, learning difficulties present before the age of 18. When it comes, they test below 1% on the psychological testing. And when it comes to adaptive skills, they're testing in the handicap range. They're also assigned a level of disability, and that's basically through IQ testing. So when it comes to people living with IDD, it's estimated that's about 4% of the general population. We know that those numbers are underestimated when in fact it's probably closer to 8 to 10% of the general population. Some of us might think, well, that's not very much. But what we do know about this population is that they're high ER users. They have longer lengths of stay when it comes to hospitalizations, and have often higher incidence of hospital readmissions and high users when it comes to community services. So that being said, we know that those numbers are underestimated, but unfortunately, despite all of that, there's really that lack of awareness when it comes to policy changing and service planning. Because there's that lack of awareness, it results in lack of response. So what does that mean for our people living with IDD? What it really means is that they're falling under the radar when it comes to palliative care, and really kind of highlights the invisibility when it comes to people living with IDD. We also know that people living with IDD, that IDD diagnosis, many of them are life-limiting and result in significant health issues. So we just kind of wanted to take a little bit of time and talk about the different etiologies. This is kind of a short list of, there's many more than that, but we just kind of wanted to highlight some of the ones that you might have heard of or a little bit more or are familiar with. So when we think about IDD, I think many of us just automatically think about Down syndrome, and it's much more than that. So we're looking at genetic deletion or genetic etiologies. We're looking at those deletion syndrome. So which results in, we're having that atypical cognitive impairment as well as the physical etiologies that come along with it. Some examples would be Fragile X, Prader-Willi syndrome, Angelman, Rett syndrome. We also know that when it comes to global etiologies, that accounts to about 30 to 50% are unknown etiologies, and these are referred to as global developmental delay. IDD can also be caused by pre and postnatal injuries. So when we're looking at things such as prenatal injuries, we're looking at things such as, you can't hear? Better? Okay, good. My goodness, we're going to be doing a dance here tonight. So looking at things such as maternal rubella, maternal alcohol consumption. So you'll hear some of the examples would include fetal alcohol syndrome, as well as maybe if you're exposed to early childhood meningitis, may result in an IDD etiology. You also note here that cerebral palsy is included in it. So a diagnosis of cerebral palsy doesn't automatically mean that you have an IDD etiology. You still have to meet the DSO criteria to be considered having cerebral palsy as an IDD diagnosis. All right, next one, please. So we know that people with IDD are kind of have their own unique needs. They're own unique in their own way. So what we do know is that when it comes to that, they have that premature biological aging. So they have a much more rapid physiological or biological aging. So when we're looking at their chronological age versus their biological age, there's about a 20 to 30-year difference. So somebody's that of a 40-year-old, they're really presenting closer to a 60 or 70-year-old. So the things that we would typically look like for in the general population for a 70-year-old, we need to start looking for those things much earlier on with people living with IDD. We also know that they have neuroatypical aging, which really means that the dementia is presenting itself much earlier, usually between 30 and 40 years of age. There's a higher incidence of Alzheimer's, especially with Down syndrome, which are much more rapid progression. So what does that mean? It really means that when we're looking at those doing those geriatric screening, we need to start doing those much earlier on. We can't wait till they reach their 70s and 80s. Most of them are not even going to reach that age, so we need to start looking at it much earlier. So you combine the biological aging with the neuroatypical aging, where kind of the end result is that they have a much their survival, their length of life is much shorter. So they're dying about 4 times more likely to die prematurely compared to the general population. We also know that when it comes to, people living with IDD, they're poor reporters when it comes to their own health, whether they're just poor reporters or because they have that atypical communication, we're not necessarily seeing those things. Diagnosing them can be quite challenging. So we're really relying on their caregivers as well as their VS support workers to be able to provide that information. We also need to take into consideration that diagnostic overshadowing or that unconscious bias, where we recognize that sometimes we're seeing things where we're just attributing it to their IDD rather than some of the other comorbid issues that might be accompanying with it. So again, resulting in that premature death. And the average age is between 55 and 64 years of age. The more profound the level of IDD, the shorter the life expectancy. So when we're looking at leading causes of death, we know that 36% are related to cardiopulmonary, 29% are cancer related. And while those numbers are not much different than the general population, what we do know is that these people living with IDD who get that cancer diagnosis, they're getting it a much later diagnosis, which means that there's fewer treatment choices and fewer treatments that are actually going to be offered for them. There's a higher incidence of gastric or GI cancers. You have a 4-time higher likelihood of having H. pylori and a 7-time higher likelihood of having a recurrence despite triple therapy. So if you're caring for somebody who maybe is having some GI issues, some GERD issues, first of all, you may want to kind of explore whether or not they have H. pylori and really be looking at how you might be able to rule out if there's any type of malignancy going on. 30% are related to nervous system, sudden unexpected death and epilepsy, and 7% are neural system disorders. So again, kind of relating that to that earlier onset of Alzheimer's with that much more rapid progression. And then lastly, looking at that distinct lifelong frailty. That frailty is different than the frailty that we see in the aged population, the geriatric population. This is the type of frailty that's specific to people living with IDD. And Tracy will talk a little bit more about that. So I just want to go on and look at this this diagram that many of you probably have already seen. So this is a diagram that many of us have seen. We kind of really use it to kind of be able to determine where somebody's at in their illness journey. When it comes to people living with IDD, it's not an illness journey, it's their life story. This is something that they've lived with their whole life. They don't know anything different. This is their story. So how do we support them? We want to make sure that we have the right team in place, the right people in place to help support them. And who are those people? That's palliative care people, as well as the developmental service people coming together to support that person so that they're living with their diagnosis. All right, passing on to Tracy. Hopefully you'll hear her better.
Not only because I'm in the city, so connections work a little bit better, but I'm also louder than George. So when we're talking about it being their life story, that it's not just about stages of illness or levels of IDD etiology, the intellectual disability, and in severe and profound and multiple, how that layers with physical disabilities. We need to understand the historical context that people with IDD, particularly those that are entering our care stream, that are in their 30s, 40s, 50s, 60s. Now, there's outliers. There's those that won't survive into adulthood, and there are those that we know and are involved in that are in their 80s and 90s. But for the majority of these individuals, their historical context is a painful one. Laws and legislations denied people living with IDD human and civil rights, rights to education, employment, and housing. And this only began to change in our recent past. About the 1970s, advocacy started to move change, and many of the laws and legislations on the books weren't actually finally changed until 2010. Prior to the 1970s, and in fact, it started in the 1800s, segregation by institutionalization was the norm. It was known as the Great Confinement. During this time, most individuals were removed from their families at birth. Families were told that their babe had died when they were still alive and institutional and being institutionalized. Some were removed at 7, 8, 9, 10 years of age and institutionalized. And they remember that. I know I've been involved in the care of 50 and 60-year-olds that talk about what it was like being put away. Voluntary sterilization, invasive medical procedures without their consent, research done on them without their consent. They endured physical and sexual abuse at the hands of the professionals of the day. This is what's key. This is what was happening in the institutionalized care. And behavioral practices of seclusion, because in this population, many of them behaviors are their language, and many of them are atypical communicators. And what do we mean by that? Is they're nonverbal. And so they may use sign, they may use text, they may use different forms of voice that they program that speaks for them. And some of them actually use micro behaviors where turning their eye left or right can be yes or no. A simple raise of the finger can mean something else. That's how refined their direct DS professionals and direct support workers get to know and become their communication partners. And so they're key to being able to translate for us when we're involved together when the individual presents to healthcare. So the average age of death, as Janet mentioned, now is between 55 and 65. In institutionalized care, it was 37. And this is in part because of the neglect and the lack of wellness care. Most of those premature deaths were amenable to good health care. And so 70% have more than one trauma experience through their life story. PTSD is common, and they've been subjected to stigma. Even our medical journals use derogatory terms we would consider derogatory now, right? That they're retarded, being imbeciles, morons, cretins, these sorts of things. So today, returning dignity and personhood is critically important. So how does that translate to what we might see or what you might see around They're institutionalized trauma that is also part of medicalized trauma because it was done at the hands of medical providers. So what we know is something as simple as seeing something that looks like a clinic, having to walk into a clinic for care, driving by hospitals, having to go to emergency will trigger their trauma and their PTSD. This is why palliative care units in hospital and dying in hospital is not where we want these individuals to receive their care when it can be avoided. This is also why long-term care, in part, is not the preferred setting for people with IDD. They're terrified by our uniforms. They're terrified having to undress for medical examinations, for routine aspects, including immunizations, needles, any of those sorts of things. Any kind of routine imaging they often have to be sedated for, so we're having to weigh benefit or burden around their risk associated with twilight or deep sedation. Many of them have been subjected to a lot of chemical restraints, including being started on antipsychotics in institutionalized care to control behaviors chemically without an actual psychiatric diagnosis. And that's created a huge problem that we have now. And we'll talk a little bit about that when it comes later on in the slide deck. But ultimately, those of us in palliative care for sure understand a trauma-informed approach, and it must be applied to all these individuals, as well as dignity and care approaches, right? And so when we're mindful, our cultural humility has to always have this forefront in mind, the levels of trauma that they will have experienced before they get in our arms. And we must be mindful of how we collaborate and integrate with DS, because what we often find in institutionalized settings is they forget their DS team. They will ask their DS worker to leave the room in emergencies, right? When they're highly distressed due to the symptoms or whatever has brought them in there, and you actually need to have their DS worker, that's their communication partner, and or their family member, when family remains involved and hasn't been disenfranchised because of historical history. And then also there's family that themselves are aged, may be in long-term care, may have their own comorbidities or cognitive impairment. So just things to be mindful about from that standpoint. So let's talk a little bit more in the chat, shall we? Because from here, we're going to talk a little bit about, so what are the tools that can help us? And when we compare that to our palliative care tools, for those of you that have talked about that you are comfortable, somewhat comfortable, more than that, have you been able to tell us in the chat, have you found our palliative care tools helpful? Yes, no, somewhat? I don't know. So I see somewhat. I don't know. That's great. That's exactly why we're here together today. So let's talk a little bit about that. I saw Disa commenting about something was horrible, and I'm sorry about that, but I didn't catch what that was in the chat.
Somebody mentioned that they had an uncle who lived in an institution and he was deaf and mute and he was sexually abused.
Yeah,
So
it's
absolutely it's
horrific.
terrible.
You know, and that raises such an important point, and thank you for sharing that. Many of us here today have personal experience, right, with family members that have ID or DD, that's, disabilities of any kind, as well as intellectual and developmental disabilities. I know my nephew has CP with ID. My brother had muscular dystrophy with ID. My cousin, Down syndrome. And when I think about their experience in the 60s and 70s is part of what drives my passion. Janet, you want to talk a little bit about Chris?
So my brother, Mark, when we looked at those etiologies earlier, he fell under the global developmental delay. So he had an IDD etiology, but we really knew what it was. I remember growing up asking my mom, what's wrong with my brother? And she said, oh, he's retarded. So even back then, she didn't know any better. She just thought that was the term that was used. At the age of 49, my brother was diagnosed with stage 4 esophageal cancer. And when he went to the cancer center to see whether or not chemotherapy would be an option, during the assessment, the oncologist asked him 2 questions: whether or not he could do his own banking, whether or not he prepared his own meals. And my brother answered no to those. And it's not because he never learned how to do his banking, but he knew to the last penny how much money he always had on him. And it wasn't so much that he didn't like to cook or couldn't cook, he just didn't like to cook. So he worked at Eastside Mario, would have his meal there and then go home. So because my brother said no to both those questions, he was not going to be offered chemotherapy because he was not going to be seen as a reliable patient. So hence treatment wasn't offered to him. That same night, though, he was clearly unable to do his own advanced care planning.
Yeah, so it's intriguing, isn't it? How our unconscious bias and not having confidence to go deeper in how we would normally gather our data points, our identification, our screening, and our assessment and understanding their stories. And one of the things that we often think when we take social histories and social stories is workplace and education. And many of our individuals that are older, that are people living with IDD, they'll tell you they went to school, but they didn't go to school. They went to work houses that were using them to make license plates and those sorts of things and more, art industries, those sorts of things. So it wasn't really school. So when they talk about school, I always want to hear more about what was school like versus now. There's a huge difference, right, in our public school system where they are getting education. So let's talk a little bit about our standard tools in palliative care and why they don't translate so well, and some of the barriers that creates. If we look on the right-hand side there, first of all, many of our tools have not been validated in people with IDD. They don't correlate their distinct lifelong frailty. Those that have, some are very robust and we wouldn't consider frail. Some might be pre-frail, but some would be considered frail their whole life. It doesn't accommodate for their lifelong physical disabilities, the biological age versus chronological age that Janet talked about, and it doesn't do comparisons to what their lifelong baseline was or compared to last year to this year. And so that creates a problem for us. It doesn't look at the burden of pain and symptoms on their baseline cognitive or adaptive functionings. It doesn't necessarily correlate that many of these individuals, because of their IDD etiology proper, develop multiple comorbidities, right? Often cardiopulmonary, certainly neurodegenerative. So many of them have 3 or more comorbidities. And so what trajectory do we look at? Are we looking at organ failure? Are we looking at frailty? Are we looking at malignancy? Are we looking at their IDD trajectory? It becomes a symphony of things to be mindful of. And so we think of tools such as ESAS. And all of us here, I'm sure, are familiar with ESAS. But we don't use ESAS in people with IDD unless they are borderline high functioning, because numeric rating of symptoms is too abstract, right? 1, 5, 10, it doesn't have meaning. So we move to a 4 or 5-point scale where we use descriptive. Are you comfortable? Do you have a little bit, right? Are you really uncomfortable? By the time we can see it, it's way higher than that. And we're going to show you how to interpret them by seeing it, because many of them smile. And some of the etiologies, such as Angelman, smiling is their normal facial expression. It's actually part of the ID etiology. Many of them smile as a learned behavior because they're afraid of us and they want to please us. And this smiling is, I'll do whatever you want, whatever you say, because of that history, right? And so smiling doesn't mean someone is pain or symptom free. PPS doesn't help because we have to look at borderline. And in people with moderate, severe, profound, or multiple, their PPS could be at 30% or less their whole life. They may have been bedbound, have enteral feedings their whole life, been nonverbal their whole life, may have had non-invasive or trach assisted ventilation. So the list goes on there. So the PPS isn't very helpful. What does that mean then for us? Is that when we're asking for PPS scores, they're not going to work, they're not going to be very helpful, and that becomes a barrier in accessing palliative teams proper when our admission criteria says one thing, but the description from the DS worker says something totally different, right? Well, what about our clinical frailty tools? Our healthcare clinical frailty tools are heavily health focused and diagnosis focused, and they aren't the frailty tools used in the DS sector. So they're not helpful. And so we really need to start using the clinical frailty tools. We're going to talk about that, that are used in the DS sector to inform. We can use the DS sector and our tools and combine them and leverage both of their strengths. Well, what about our identification of cognitive decline or dementia? And we've heard that that starts early. Well, our MMSEs and our MOCAs are not used in people with IDD. There's a different tool. It's the NTG tool that's used, because many of them would not differentiate many of those things. Many of them don't know what a clock is. They wouldn't draw a clock, or they may know a clock, but they can't draw arms. And how do you identify the difference between a camel with one hump or two humps? And, you know, the list goes on. So they're not the tools that are used by DS specialists. So we don't want to use them either. In the long-term care setting, and in other healthcare setting, the CHESS score, right? It's not validated, and it's actually been devalidated for use in the IDD population. So that can't help. And in the long-term care setting, CHESS scores are used a lot. And in fact, the personal severity indexes in long-term care that are part of their point-click care documentation are used, and they can't be very helpful. And then when we talk about our CAM tools for delirium, they're not very helpful either. An aspect of it can be an acute onset of confusion that's different from their baseline, or decrease in level of consciousness for identifying hypoactive delirium. But hyperactive delirium in this population is easily confused with dementia, depression, or the normal atypical behavioral communication. So we're going to talk a little bit more about that. So our early ID tools and our typical palliative care tools are not particularly helpful and need specification in this population. So let's talk a little bit about our earlier ID. of needs and our earlier idea of needs and how we look at the surprise question, and are they in their last year of life, their last 6 months, their last hours, days, weeks, or less than 3 months? So research has been done around that, and certainly more interest has been building. Not that the DS sector hasn't been doing that research, they have, but what we see as far as the research has been done over the past 15 years is only now finally getting published because more interest is happening, and that's being published in the last 5 years, right? And so there's this here is, I know you can't see it, it's small, but we've put stuff here with links so that when you look at our reference list and the links to the tools, when you get the slide deck, you can do some more self-directed learning and familiarization. Here in Ontario, a lot of work has been done by the two groups. It's the H card, right, which stands for Healthcare Access and Research in IDD, along with InterRI. And they did a tool to try and help us identify frailty. We're talking about frailty right now, because what we know in this population is frailty as a predictor is correlated with decreased survival. And it's a significant corollary. And so, can we identify frailty in the people that you're involved in their care? And what is it that we're looking at? And so, when we talk about what do these frailty tools do? Well, the number one thing that they do is they look at a accumulation of deficits. What they're not looking at is individual deficits proper, right? So they're looking across domains: physical, psychosocial, cognitive, communication. As well, they add in service needs, because what we look at is how are the intensity of their service needs increasing? And what does that tell us as an early identifier and potentially valuable prognostic indicator, right, around survival? It's more about that accumulation. It's even not just about the IDD etiology and their comorbidity prognostic indicators coming together in our earlier ID tools. And so what we're looking at is, do they have 12 or more health deficits, right, across our domains? And for us, we know the 8 domains of care. And how are they comparing to their historical baseline? And what was it like last year? And then their self-rated health, right? Are they feeling sicker? Because it's been their whole life story and they're used to burden and differences, and they don't know anything other than how they were born. When they start feeling unwell, that's a red flag warning sign. So that means then we have to be able to communicate and read their languages and be asking those questions with our spider senses even. That high intensity need correlates with caregiver. So whether it's family or their direct support working team, when they're distressed by the high intensity of care that the person now needs, that's correlated with frailty. Not robust, not pre-frail, but frailty in people with IDD. that's an early warning sign. We could be in our last year of life. So it's that detective putting that whole picture and understanding how it can look different in people with IDD. So if we look at that picture on the right, if I said, when you look at this person with IDD, do you think that they're frail? Pop it in the chat. Does that come to mind? When you look at this person, you can tell their total care by looking at them, right? You can tell they have contractures, they have poor muscle wasting, right? Their postures are different, they've got contractures. I see some are saying definitely frail, some are saying not necessarily. Yes, I think that they're frail. So this is where I want to challenge you. You're going to see people that have been frail and have looked like this their whole lives. Like I see H saying there, they may have been like this their whole life. It's not about what we typically know with average aging accumulates and can be that visual cue that somebody is incredibly frail, right? So have they been like this their whole life? And then can we demonstrate an increase in that that's associated with their aging? So if you're meeting them at 30, we ask questions about to the person, even when they're severe and profound. We talk directly to the person. We want it, their voice amplified, even when they're atypical communicators. We don't talk over, we don't talk to their family, we don't talk to their direct support workers, and we ask permission. Can we speak with them? Is it okay for them to share with us? Because we recognize that they're your chosen person, they're your trusted person who's going to tell us your voice, right? Amplify your voice, not be your voice, amplify your voice. So some of our common language changes. And so when we can correlate that 10-year, 20-year, 30-year with how they look now, and we can see that changing with aging, now we've got IDD frailty, right? It's not just about what we would normally assign as frailty. Then we have to measure baseline. So there's baseline things that we want to know about the individual. And then we're going to look at what were the baseline physical and or cognitive or language barriers before. What are their bodily system changes? Has it increased, right? This brings in what we will be showing you is the Palliative tool. Pain is an early warning sign in this population. But what we have to be mindful of, we're going to talk about pain. Many of them don't have their pain managed, right? And so we often have to measure and see what happens when they get their pain managed because people change. And I bet you many of us have seen that when we get involved and it looked like they were rapidly deteriorating, that maybe we were going to have to apply our advanced care planning, our goals of care, that maybe they did fit an end of life trajectory until we helped them with their pain and symptom burden. And then did they restabilize? I know I often see that a lot. I see that a lot, and I do a lot of consultation in this sector. And 2 years out, 3 years out, 5 years out, they return to baseline or near baseline, right? But what's the nuance there? So imagine that their pain was well controlled. What we look for is the pain severity increasing in intensity, and are the pain events coming closer together, because there's different causes for the pain events coming closer together. Now that has high corollary value to estimating clinical survival. Have their meds increased? They often have multiple specialists with multiple prescribing. What was their number of medications a year ago? What is it now? We look to compare that. That correlates with multi-system symptom burden changes, right? So that gives us a clue as well. And it gives us a clue potentially when the doses are increasing, their meds have had to have been changed from first line to second to third line, tells us about destabilizing symptom burden. And as we mentioned before, asking about, has the service needs increased? How are the families feeling? Are they overwhelmed? Are they burning out? Do you see the distress in them? When we do our caregiver burden assessments, when we're actually talking to their DS team, within the DS team, they have different funding envelopes that they use to augment when there's high intensity needs. That's called passport funding here in Ontario that can be applied for and optimized. And for some, it can go as high as $30,000 a month, right? And so we ask questions about, are they on passport? We ask their team, have you had to increase into the high intensity service funding for the individuals? Those are early warning signs for this population. So that's the early warning signs. So far, it has not come together in one tool. Some of the tools that identify IDD specific frailty are 42 questions. And it's helpful in the inter-RI that they now call here in Ontario as part of Home and Community Support Services, the inter-RI HCID. And it will ask the Home and Community Care coordinator to go through, it pops out a score and it will tell us this person is definitely frail, high warning, wrap the right team and services around. Most of us don't have access to that. We don't have it in a nice, tidy tool. And so now we try and just teach one, reinforce, right? And go look and enhance your own knowledge when you're involved in these individuals' care. So when we talk about early warning, it's the blend of the IDD etiology, what it looks like when it progresses, what are the symptoms, symptom burden, and symptom changes that we'll see. What are those comorbidities? What are those trajectories? What does it look like? The one thing I would caution you on is we recognize that unplanned hospital admission or unplanned ER transfers is an early warning for us in the general population. That's not true for this population. Many of them get their primary care in ER. They have access issues. Things aren't identified. They're too terrified. They have problems with not getting a primary physician or nurse practitioner. And so things, carry on late and then it blows and then they're in ER, right? And so it's always about what were they in there for, right? Because it may have just been a UTI. And is that typically what happens? And is that how they get their antibiotics most efficiently and most effectively because there's challenges with primary care? Key questions to be asking. So here's the first early ID tool for people with IDD. It's called the Palliative tool. It looks at baseline. It walks you through the questions to be asking about baseline, what changes are being seen. The wonderful thing about the Pally tool is anyone can use it. You don't have to be in a clinical role. It doesn't matter what your role is. And it also doesn't matter if you're family. We teach it and use it with family when they're primary caregivers. It walks through 39 questions that we deliver in a conversation and a dialogue, not boom, 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 boom questions. That can be overwhelming. But it walks us through IDD, health signs and symptom changes, behavioral changes, their adaptive functioning, their language changes, expressive and receptive. It walks through how of their ADLs or IADLs and their socialization changes, and it starts pulling in some of the IDD specific frailty questions. And so regardless of the level or nature of disability, this tool can be used to kind of give us a picture where they are in their baseline, even before we're trying to figure out a surprise question, although that is on the Pally tool. It acknowledges enabling communication across the team. It also acknowledges intuition, family, people who know someone really well. And with their DS workers, many have been caring for them for 30 years or more. They know them very well. It acknowledges that gut warning to say something's changing. I like to tell family and I like to tell their DS support team, if you're worried, I'm worried. Let's get to the bottom of it together. Let's get the pictures. Remember the self-reported warning of the individual is a big dot, red flag. I want to ask the individual, how are you feeling as far as your wellness, right? Right? How do you feel your health is right now? And then that triggers further assessment to assign a meaning for what we're seeing and the change, diagnostics, those sorts of things combined with the case history, etc., drives specialists' involvement. So primary with their DS, with specialists, whether chronic disease or palliative specialists, get all wrapped into this tool. What's on it there is, I think it can sometimes be challenging to get a hold of it. It will definitely be in our resource guide and toolkit. In the meantime, we've provided the email address of the designer of it, and she is happy to send it out for your organizations. Would healthcare providers be asking these questions to family members of the person with IDD or the healthcare provider? Everybody. Remember, we said it's the individual, the family, their DS workers, and healthcare. We see everybody on the team equally, and the person and their family are the head of the care team. And what's also interesting is many of them don't have family. And in those instances, the person with IDD actually views their direct support worker as their family, right? It may be their closest relational person. And so in IDD, we talk about relation is not based on family or next of kin. Relation is based on who the person knows and trusts, who knows them well, who's their communication partner, who can translate their communication. It doesn't matter whether they're atypical, even in severe and profound. So it's about who's their closest relational person and partner. And that very often may be family, and sometimes it's not. So the tool is for anyone and everyone. It's all just about how do we walk through it? How do we teach it? How do we use it? So that can be, a put on the button list about how do you want to use it in your practice, and how do you want to use it in your organization or your program or your service offerings and all of those things, so we can get to them sooner, because we're getting to them late and they have access barriers and our admission criteria is preventing palliative expert teams to get to them. And what I'd like you to be thinking about is if, and this is true, we can identify they actually meet IDD specific frailty indicators, most of them will die in under 3 years. But what we don't know is what if we manage their pain and symptom? Then they could live longer. And we may no longer consider them IDD specific frail. They just might look that way from our typical healthcare aging lens. And so we really want to be able to get to them sooner. What's the worst that can happen? Is you say, you don't need us anymore, right? And so we have to be thinking about how do we work those gray areas? How do we get to them? Can we get them on board, optimize, and then they may not even need us anymore. But now they know, they trust, they've had a relationship with us, the team, the person, the family, right? And they're very happy when they get to see us again. So it's, our investment in delivering the best palliative care approach. We've created in the deck here some of the early warning signs by some of the IDD etiologies. We're not going to cover them, but they're there for you to look at them. Our IDD specific tools, when you go back and you look now that we've shared what we've shared about our typical tools, whether it's the gold standard framework, whether it's SPIC, whether it's SPIC for all, which by the way, we're teaching the DS sector to use SPIC for all, because family and the DS sector, many of who are not healthcare clinicians, right? They're behavioral analysts, they're social workers, they're behavioral therapists, they're therapists that work with communication and unlocking atypical communication styles. There's IDD specific psychiatrists, psychologists, IDD specific loss, grief, and bereavement workers, like the list goes on. Like there's so many in the DS sector that you may never have even heard of, that there's this incredible group that we can be partnering with, right? To make this such amazing team. And so we teach them the SPIC for all. And to how to walk through with family members, what are those things that they're seeing when we're trying to look at multi-system comorbidity burden. So it's not a one and only, it's a 1+1. The Pally tool plus our early warning tools, right? Combined together, but always looking at baseline, right? Okay. Because you won't see IDD specific things on our tools, right? That's why we use a combination. Well, one of the things that you said you wanted to learn today was about pain and symptom management for this unique, high risk, highly vulnerable, highly amazing group of people. And so the tools that we use to identify pain and symptoms, to identify changes, to try and figure out what is the cause of some of these changes. The first tool that's used is the help tool. The help tool, if I can magnify it here for you, is the common tool used in the DS sector. And so they look at and observe for, are things changing? Not only health, but mental health, psychosocial, spiritual, physical, all of those sorts of things, right? What could be the underlying causal factor? Is it environmental? Is it lack of support? Is it the wrong kind of support, right? Who is their person, their chosen person? Is it the care setting? Institutionalized care, are IDD people failing? They die sooner. They die sooner. what we know is they do way better at home for as long as possible. And then to go into congregate or group settings. In the DS sector, they have various different ones. And they also have the ones for individuals who are high intensity, highly medically complex. What we know is when they're in the arms of DS, congregate group home settings, it's protective against IDD specific frailty. It almost doesn't happen. It shows you what happens when you're in the arms of a skilled and experienced care team. It also doesn't happen when they're at home as quickly, right? But when it does happen, the change can happen pretty quickly over a year, and family can become totally exhausted and burnt out very rapidly. Is it a combination of their lived experiences? Is it part of their trauma history? And where is their psychiatric aspect coming in? 50% or more of people living with IDD are dual diagnosed, meaning they have psychiatric issues. They have mental health issues. And so it becomes, again, this level of detective work. So our screening tool for pain and symptoms across all of our palliative 8 domains starts with this help tool. Then we ask to layer on those who know them best, specific changes by their IDD etiology, and for them as an individual person. And so we ask them to do this, and we have the conversations and dialogues in our ID screening and assessment around that. All right, so where do we go from those tools? The links and a video to show how it's used are in the slide for you. Well, what about our pain tools proper? We talked about ESAS is too abstract. And many of our individuals, moderate level IDD all the way through to severe, profound, and multiple, numeric on the ESAS is just way too abstract. In fact, all of the symptoms, the common symptoms on the ESAS are just way too abstract. And so when we're asking questions, we have to use plain language. Communication with people with IDD is incredibly direct and incredibly plain, right? And sometimes we think the direct words are culturally insensitive, and that's different in this population. We say, you're dying. Do you think you're dying? Dying has meaning, right? Well, what about pain? Pain's a difficult word. For most people with IDD, it doesn't have any meaning. They've had pain their whole lives. Many of them, it hasn't been managed. So let's talk about comfort, discomfort. Are you hurting anywhere? Are you sore anywhere? When we're doing our physical assessment, and we're trying to see, rigidity and spasticity, does that hurt? And what is your experience? And when you're having a bad day and you're doing a lot of this behavior, and we show them. Because one of the language behaviors that IDD specialists will do is they will mirror an individual's atypical. Because the first thing that does is it shows the person, I'm seeing your language. And so if they go T, 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 I'll say T, 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 T. And they'll stop and they'll look and then they'll go, okay, she's speaking my language. And then I'm asking their communicator partners, tell me what TTTT means. I had an individual that they said T means that's what he does when he wants attention, or when he's trying to say, look at me, I have a need. But now what he's doing is he'll go T, and he'll walk over to this lamp that has these fringes, and he'll do T, and he'll play with the fringes. And they're like, that's new. And we haven't figured out what that means. Well, I had a suspicion. Behaviors like that are new are self-soothing. My first thing is pain. So we went after that. It was pain. The lamp and the fringes, the self-soothing behavior settled down. They will do when someone does this a lot. That's their language. Or they're doing this a lot, and that's their language. They'll do that when they're trying to figure out, talk to me, I'm talking back to you. I haven't quite yet don't know what that means, but you know what it means, and you don't know that I don't know what it means, but you know that you and I are in dialogue, right? Where we might think, well, that's insensitive, and it's not. There's wonderful videos about that and the kinds of stuff behavioralists do. You'll see that a lot in people with that are really on the disabled area of autism spectrum disorders. So we translate into words, right? And then we have to translate behaviors into pain. So the only tool that's been validated to translate people with IDD's behavior into pain is this tool that you see here in the middle, the green one. That is chronic pain scale for nonverbal adults with IDD. It has a 95% accuracy, and it's been validated. And it walks through rating these different behaviors that are common indicators, right? Well, that's part of it. So it can kind of give us an idea of where they're scoring that, yep, that's pain. Now, how bad does it feel? This is where we layer the DISTAT, right? Our DISTAT tool is about distress and behaviors in people with IDD. And so we want those who know them best to tell us about what's their baseline, what are their content and comfortable behaviors, content and comfortable languages, what does it mean? Tell us what the distress language is, what you've learned, so we can share that with the team. We ask that this kind of stuff be sent for any clinic, any ER transfer, any hospitalization, and there are healthcare transfer tools that are quick and dirty that we're asking their DS team to be filling out to send with you now. So that's a clue to ask for it, right? It started in COVID. It's moved out of COVID. The tool is on Surrey Place's website. Surrey Place in Ontario is like the center of excellence around IDD. They do a lot of research. They have a residential offering. They have transition beds. They have symptom management beds. They have everything, every specialist, there, and they create best practice, good practice guidelines. They teach, they disseminate, and so the list goes on. Okay, so what about this dementia that Janet was mentioning? Starts early, so we have to apply geriatric assessment things in their 30s and 40s. We said the MOCA, the MMSC don't work. What is the tool that's used? Well, it's the NTG. The NTG tool was created by the National Task Group on ID and Dementia. It's the early detection screening, right? This is what the psychiatrists, the geriatrics that work with people with IDD, that's the tool they use. We often hear from physicians, we knew that the tools that we had for this wasn't working. We've had an opportunity to talk to GAIN clinics and palliative specialists and chronic disease specialists, and like, hallelujah, we just didn't know that this existed. That I'm getting in my toolkit right away. We already talked about why the CAM tool doesn't work particularly well, right? It's hard to differentiate dementia, depression, and delirium in this population. So there's additional screening that when we're looking at delirium, we're also marrying it with the NTG, decrease in level of consciousness or increase in hypervigilance and alertness and increase in behaviors, and their team thinks their spider sense that maybe this is dementia onset, but they're not too sure and we've got to rule it out and these sorts of things. So you get the idea. All right. The interesting thing is people will start to show, people with IDD will often have one or two significant clinical depression episodes as a warning sign dementia is going to start. And then dementia, we know, progresses more rapidly in these individuals. We know a lot about dementia and Down syndrome. We're getting to know more about it from an experiential standpoint. Pretty much all of these individuals will develop dementia, just what level. It may not progress all the way to an Alzheimer's, but these individuals have cognitive impairment as part of their etiology. That's the IDD aspect of it. There's a central nervous system degenerative component. So of course, that's going to start to succumb over time. These individuals get Parkinson's. They have strokes. They get Lewy body. Some of them get ALS, right? So high medical complexity needs appropriate specific tools. We talked a little bit about, well, how the heck are we going to tell the difference between depression and all the rest of that? Particularly since we also know that depression can be driven not only by pain and symptom burden, but chronic inflammatory processes, whether it is macro observational that there's inflammatory, these individuals have pro-inflammatory cytokine dumps their whole life, right? And it causes brain fog, it causes cognitive decline, it causes pain to increase, and it causes depression. And we know with prostate cancer, which many of the fellows can experience the same as the general population, depression is an early warning sign of prostate cancer, right? So what we know in the general population, we're still mindful of with these individuals, but that mood. And so mood screening tools, these ones have been developed in Scotland. So much of what we know and the tools that we use have come from areas that have been researching, validating tools for decades. And a lot of it comes out of the UK. And no doubt, because the UK will often follow from pediatrics, their palliative teams into adulthood. We don't do that here. You know, here, if you're involved with sick kids, many are, and then when they turn 18 or 21, they move into the adult medicine world, and so much of who knew them the best and the support and considerations are cut off, and we have to start over. And so there's a huge trauma, period in there that their DS workers are trying to support and guide them through. But these are the mood screening tools. In addition to your area of practice, the tools that you'd be using and asking. And these also come in picture form for the individuals to be able to self-report as well. And there's a lot of other tools out there that are in our key resources at the end, and videos you can find all over the place on how to use them. A great website is Palliative Care for People with Learning Disabilities. That's what they call IDD in the UK. We get a lot also from the Netherlands. They use a lot of self-advocates, and they use a lot of people with IDD to inform their tools, their processes, how they want us to intersect, how they want to be treated, talked to, all of these things that we're sharing with you today. Australia is an early adopter. So there's all kinds of rich stuff. We have half an hour to go, so I'm going to whip through the next part so we can get to the case study. Common pain and symptom concerns: pain, dyspnea, seizures, behaviors, and pharmacological conditions. There's so much, and maybe we could talk, have another time to talk and break down each of these ones separately. But for now, what our takeaway message is, these individuals have a high incidence of pain that has not been addressed. Part of that is because they may have to rely on caregiver report. Caregivers bring their own lens and fears with it. So we have to break that down into etiologies and comorbidities. If it hurts other people, it's going to hurt these people. When we talk about Tylenol is overused in this population. Our pain management approaches start with adjuvants first. Then we layer on opioids as needed. Many of them will develop or already have central or obstructive apneas. So we start lower and go slower when we're using opioids. Opioids, because they are neurotransmitter medications, right? And we're looking at their agonist property to shut down signaling. Shutting down signaling could be problematic depending on the signaling the person is depending on, right? And so it can also, when we manage pain, smooth transmission of hyperactive signals. And so in those instances, we can make other symptoms that they experience worse when we pull opioids on. There's no right or wrong way. There's just practice pearls, and sometimes we just have to try in order to figure it out. Anything that we give from a medication standpoint can cause behaviors to escalate. And it can be very difficult when we're using certain medications to differentiate between EPS and their repetitive, or what used to be called stimming behaviors. And we use anticholinergics for a lot of different reasons, which brings us to dyspnea. There's lots of different reasons for dyspnea. I'm just going to jump ahead here a little bit. And so when we put in here a chart, and when you look at the chart around pain, we've put in the kinds of common pain types associated with the etiologies. And we've put in some pictures to give you an idea. And then some of the etiologies that get horrific scoliosis changes, where they have screw and pedicle surgical fixations. And particularly in something like Prader-Willi, they almost all have this. And even though it was designed to help, there's tremendous pain associated with it. So just because it stabilized something, the pain is often still off the Richter scale. And certain things like Prader-Willi, they're at high risk of gastric perforation, right? For, those different causes. So we love to just focus on pain one time. When we talk about, on the left there, you see a picture. That's a picture of complex regional pain syndrome and the associated flexion spasticity and contractures that can happen chronically or intermittently. On the other side, you see flexion and contracture in the IDD etiologies. It doesn't look any different. So if we know complex regional pain is excruciating, what does it feel like for these individuals? And if it's all you've ever known, if that's been your whole lived experience, why would you tell anybody, even if you are able to suffer? So in people with IDD, we assume pain until we rule it out. And we use that as a palliative care line of practice too, but all the more, 80% of these individuals have pain that they've never been asked. And if they've been asked, they've been given Tylenol, and we haven't optimized pain management. Many of them have lateral deformities, hyperextension deformities, or forward postures. And how that relates to pain is, for every inch someone's head posture changes, it adds increased weight on the neck structure. This is an individual, muscular dystrophy with IDD. Look on the left side at that posture change and the agony that would be associated with that. And we often just think, we forget to think, we can become desensitized. He had surgery to correct his posture. That's him on the right. How heavy is your head? All posture will bring in head weight. And so every inch the head deviates will add 10 to 20 pounds. On spinal column, muscular structure. Well, if your muscular structure and your skeletal structure is small in structure, or fragile in structure, that's going to hurt a whole heck of a lot. When you look at this first fellow there, he's got a lateral deviation, he's got contractures, he doesn't do full extension, he's smiling, but he's going to have pain. And what about all of these individuals? All of these individuals are in the mild to borderline. You see the forward head posture? How many do you see it in? All of in that picture, right? So some have particular in Down syndrome, but other causes what we call atlantoaxial instability. That's kind of important to know and understand. Pain is the first warning sign. We can get spinal cord compression. That's a palliative emergency. Pain management, often musculoskeletal with a neuropathic component. What about dyspnea? Well, part of the things we're mindful of, it can be central, can be postural, it can be obstructive, it can be body habitus. Some of the individuals, there's huge variance. But in the first picture that we looked at where we said, do you think this person is frail? And some of us thought, no, and depends on if they've been like that their whole lifetime. Even so, in someone like that, when you look at their muscular structure, that tidal volume ability is compromised. So they may not be hypoxic, but workload dyspnea can be at work there. And we also know many of the individuals don't tolerate O2 cannulas. They don't tolerate CPAP face masks or BiPAP in general. If they've got a pneumonia and we know we can address it and we want them on antibiotics and the person is offered just a temporary trach so we can help that lung expand so they can breathe, sometimes that's not what the person wants. And if they've had the experience with a trach before and just the thought of it, and we see distress behaviors as we're talking with them and to their chosen people about it, we need to delve deeper. Because I've had individuals say, I don't want to trach again. I just want to go home and we get everything we need in place. So some of the things are novel approaches. And what I often don't see us using, and particularly perhaps at end of life as a comfort measure, is pulling in our RT therapists to be thinking about if they can't tolerate CPAP, BiPAP, trachs, but we want them comfortable even over the last year of life for symptom management. Do they match the indications for a cure-ass approach? The idea came from iron lungs and polio. Now it's polio portable. The operation box is no different than on a CPAP. RT can set it up. It comes with this tortoise shell designed for the size and frame of the person, and it makes a right? It creates a suction, and then it opens the chest, and then once we've got it set up, we turn the volume down, and it can be a huge comfort measure. So challenge the status quo. Think outside the box. What else can we do about that? And pulmonary damage is, in many cases, is actually part of the IDD etiology. It's not necessarily because of recurrent aspiration pneumonias. Even with G-tubes, many of them will get aspiration pneumonias. It's not preventable. It's my message, right? So G feeds to the end, right? Unless they don't, we're at that point and they don't want it anymore. Prophylactic antibiotics all the way to the end as a strategy, right? Many develop COPD. They have no idea why. It's all of that underlying pathology that we don't have all the answers to. The thing to be cautious in dyspnea is we use anticholinergics as our last choice. They often have high anticholinergic burden because they may be on depressants, on antidepressants, because of their seizure meds, because they are on inhalation therapies, Atrovent, salbutamols, they're antipsychotics, the list goes on. They have high cholinergic burden, so it can be challenging for us to identify the adverse effects of an anticholinergic if we're going to add it. Does it mean that we don't? Of course, we're going to use what it is matching benefit burden to the individual, where we're meeting them at, etc., right? And being mindful that it may exacerbate their repetitive stemming, soothing behaviors, right? And certainly it can pop them into psychosis, right? Many of them are on antipsychotics. We talked about that a little bit, because it was appropriate and because it wasn't appropriate. It was used as chemical restraints, and now we can't get them off. So what's the drug-on-drug interaction? Is it going to decrease, their seizure thresholds? And the list goes on. Okay, seizures, very high prevalence. Epilepsy and developed seizures. Many will have seizures at end of life. Seizures are challenging to manage in this population. It's often a refractory symptom. Practice Pearl. They often need 3 or 4 seizure meds layered, one on top of the other. If you see Keppra on board, I can never pronounce its generic name, levetiracetam. Okay, I do think Keppra is easier. That can be a warning sign. We've got an issue. Breakthrough seizures are a warning sign. We could be in our last year of life or less. There's all kinds of behaviors. We won't go into them, but antipsychotics are not first line. Behavioral analysts are. So some of the, there's more in here for you. Polypharmacy is a big issue. Prescribing cascade is a huge issue. Here's an example of a prescribing cascade that happens for many people with IDD. Anticholinergics, cognitive dysfunction. We see dementia. We assume it's because of their IDD. No, it's not. When they get dementia, they get incontinence, issues, anticholinergics, more more burden. We add in PPIs. We go more constipation, laxatives. We go more. They may be on gabapentin or other anti-seizure measures, and they develop edema. And we go into diuretics, and then they get a worsening of their movement disorders, and they're high risk. Their pharmacodynamics are different. What we know is their cytochromic enzymes are different. What we don't know is to what degree and how, their bioavailability or their absorption. And so the list goes on.
So really kind of looking at that, but how do we advocate for these individuals? Someone earlier mentioned about the advanced care planning. There's actually a tool that's been created by the Australia. It's called a supportive decision-making tool. And it kind of guides how you help that individual to make decisions. It could be as simple as whether or not I want to go on vacation, or even simple as, or not as simple as, a little bit more serious, like how do I want my care to be? We really want to make sure that we're highlighting pain management, really make sure that caregivers are accessing all of those passport dollars to optimize all the services that they need to be able to support their loved one. And the last thing that I really want to say is that when we're looking at quality of life, it's what they say it is. It's not our idea of suffering might be very different than what they're feeling. Looking at the platinum rule versus the golden rule. So the golden rule is do unto them is what we would want them for them. But when we look at the platinum rule, it's not what we think we would want, but it's what they would want for themselves. See the person, disability and support equal capability. So then lastly, we wanted to kind of highlight the importance of bringing that team together. And we talked about having not only the palliative care team and developmental service team, we want to bring them together and having that be the model of care. How we want that, the two sectors to come together, looking at those competencies, both in the DS sector as well as the palliative care sector, and really having that integrated team approach. And that is it. So questions. We've allowed ourselves all of 4 minutes for questions. I would agree with you, Shirley. And I've seen parts of this presentation before, and parts that Tracy speaks to, and there's certain things that she said today that I haven't heard her speak to before. So she definitely added even more. So thank you, Tracy. But yeah.
You're welcome. Right in what you're thanking me for.
Just how you always, I've heard you speak to many of these slides before, but even tonight I've heard you say things that are different. I haven't heard little pieces that, I didn't hear her say that before. So just kind of comment or agreeing with one of the people saying there was so much information to kind of take in.
It's a lot. It's a lot of information over 2 hours. Yeah, we get your pain.
There was a couple of things that came up just around the idea of how we do assessments. And I'm pretty sure what I heard is it's a mix of observation, talking to the person themselves, and then also asking their caregivers.
That's right.
And then there was
So that's why if they're going into a physician's office or if they're going into emerge, normally, often we'll see the DS person is asked to step out of the room. What we really want to advocate is no, they need to stay in the room. We need them because they're going to help us gather that information that we wouldn't necessarily get without them being there.
Somebody else asked about if you had any advice for healthcare workers on ways to not miss underlying health issues, such as cancer, when working with people with IDD.
Yeah.
It kind of goes back to that diagnostic overshadowing, that unconscious bias, where some of the things that we're seeing, we're just attributing it to being to their IDD etiology, and not necessarily considering that we know many of them have multimorbidities. So looking what else is going on besides their IDD.
Yeah.
And again, really kind of going back and really learning knowing what their baseline is, and I know we're running out of time, but even when my brother had his diagnosis, he was complaining of pain probably a year or so ago. He complained about shoulder pain that we just thought because the work he did that's what it was. Never in our wildest dreams would we ever thought there was a cancer diagnosis, and that's something that my sister and I we kick ourselves about, that maybe if we'd have recognized those changes and not just blamed it on that, then maybe the outcome might have been different.
Yeah. I so agree. Uh, I think the practice pearl and the starting point is you must always maintain a high level of curiosity and assume nothing.
Mm.
Assume nothing. I think something's wrong. What is it? And almost forget in those moments when we're looking for early identification issues that they don't have IDD, right? Mm-hmm. Ah,
I think there's
Joan.
been lots of also
Joanne.
just lots of positive here, and so Carl and I are so grateful to all of you for being here with us. Somebody, Suzanne really likes your glasses,
I
Tracy.
see that. That's what I'm chuckling
There
about.
you
Thanks,
go. There you go.
Suzanne. And someone, I saw people saying I could listen for another hour. I'm like, gosh, how fabulous are you? It's the evening and we just dumped so much in your brain overload leaking out the ears. But I think we've at least sensitized you to how special, how distinct, why it's so important, our learning objectives. And you're not going to walk away from this retaining everything, but it's a starting place, right? It's a starting place. And the key is these are people, not diagnoses. We say that in palliative care all the time. How can you see them? And how can you get to know them? You know, it was interesting there in that one video that his hospice nurse, who's been following him for 12 years, kissed him and
Mhm.
she greeted him.
Yeah, and that I had the comment there about just, I know we've done some work with
Mm,
folks who work in group homes
right?
because their grief is very difficult because of the nature of their close relationships.
Ah,
Um,
And we make that
well
assumption
said,
that
Val.
they don't grieve, and they absolutely do. So not only are you supporting the other residents who live in the home, but as you know, these DS people, because many of them have been supporting those individuals for many years, and we
Yeah.
need to be better at
And
that.
they grieve hard, the same as for their own family member, right?
I think even more.
Mm-hmm.
Like I remember the two community living people that supported my brother, like one of them especially. It took her a long time. She goes, I'm never going to get that attached again because it hurts too much.
mm.
And then they do, though. They get
And she
on their
still
bike and they do it all over again. It's just that grief expression. They need to go through that. And then they're like, nope, I'm doing it again. Yeah.
So before too many people hop off, Carl has some logistics, but I'll just say one more quick thank you on behalf of the folks here in Champlain.
Pleasure.
Tracy, you got to come down and have a visit because you know you had your Champlain Day today. So
I would love it.
it's been great to have you all here, and we'll definitely get you back.
Thank you. Thank you.
Yeah, thanks so much. And I've just for the logistics as Val was mentioning, I have the link there as normal to the post-session evaluation just in the chat there. So you can click on the link and do the evaluation if you want to get your certificate of attendance there. I'm also gonna email it out next week. So if you don't feel like doing it now, you could do it next week too. Wonderful. Well, thanks everyone so much.